All right, let's get started. So, good evening. My name is Sierra McCann, and I am the Regional Vice President for the Southeast for Susan G. Komen. And it is my pleasure to welcome you to today's event focused on advancements in breast reconstruction and surgical options for lymphedema management, sponsored by our friends at Cancer Treatment Centers of America. Breast reconstruction can help restore the look of the breast and may help you feel more comfortable about how you look after a mastectomy. Komen has a wealth of information posted online to help aid you in the decision-making list of questions that you can ask your plastic surgeon. This information can all be found by visiting Komen.org and searching for the keywords breast reconstruction. A few notes before we begin. We will be recording today's session and it will be available for later viewing. While our speaker is talking, please feel free to post your questions in the Q&A feature or in the comment section. We will get to as many as we can during the designated Q&A times. And lastly, today's session will feature surgical imagery that some may find uncomfortable viewing. Just wanted to let you know as a heads up. As mentioned, tonight's event is sponsored by Cancer Treatment Centers of America. We are able to present conversations like this due in part to the generosity of our sponsors. CTCA serves locations across the United States through their comprehensive care centers and outpatient care centers. Their state-of-the-art cancer centers are staffed by cancer experts who use leading-edge technologies and advanced cancer treatment options to deliver personalized, whole-person care. Cancer hospitals can be found in Atlanta, Chicago, and Phoenix. Outpatient care centers can be found in Chicago, Gilbert, Phoenix, and Scottsdale, Arizona, as well as Gurnee, Illinois. Today, we will have the pleasure of hearing from Dr. Daniel Liu, a plastic and reconstructive surgeon at Cancer Treatment Centers of America, Chicago. Dr. Liu specializes in all forms of breast reconstruction, including microsurgical tissue transfer, and offers surgical treatment options for upper and lower extremity lymphedema. At CTCA, Dr. Liu combines cutting-edge technology with exceptionally compassionate care. Dr. Liu is board certified by the American Board of Plastic Surgery and is an active member of the American Society of Plastic Surgeons, in addition to being a published researcher and dedicated educator. Outside of CTCA, Dr. Liu enjoys spending time with his wife and daughters and is an avid photographer who continues to hone his skills on the violin. Dr. Liu, thank you so much for joining us.
Hi, good evening. Thank you so much for the nice introduction. I'm going to start sharing my screen. All right. Sierra, are you able to see the screen?
I can.
Okay. So we have just under an hour today, and I've been with CTCA over the past 8 years. I focus mainly on breast reconstruction of all types, but also have a sub-practice in lymphedema management, which everybody knows affects a lot of breast cancer patients. So the bulk of my talk today will be about the recent updates that we offer in breast reconstruction, as well as a general overview of all the different options that are available to women for breast reconstruction. And then the final portion of my presentation will focus on surgical options for lymphedema treatment. So a brief disclaimer that I'll be discussing a lot of medical procedures and showing examples of patients. And obviously not all of these examples can apply to specific care. So please talk to your own surgeon about any specific medical advice. So first, I want to describe how we generally approach the breast. The basic principles are we have to recreate as much of a woman's original breast as we can after she's gone through both surgery and or radiation treatment for breast cancer. So that means restoration of a combination of different elements in the breast using different types of materials, such as prosthetic devices versus a woman's own tissue. So that means we have to focus on things like how the skin drapes, the presence or absence of a nipple, the position of that nipple, how to fill the volume of the breast, where that volume sits relative to the chest wall and the ribs, as well as symmetry between the two breasts. So these are all the different biomechanics that we think about when designing a breast reconstruction, and that's why it can be so complex and take many procedures for some cases. In general, the reconstructive goals for breast reconstruction includes maintaining preoperative form. In some cases, there's an element of cosmetic enhancement at the time of the breast reconstruction. And then a significant portion of my practice involves revisions of previous reconstructions, especially when things haven't gone as planned or has been affected by things outside of our control, such as radiation treatment. The considerations that we have when evaluating patients include surgical ones for patient safety mainly, and that has to do with a person's age, body mass index, distribution of fat throughout the body, the anatomy or size of the breast, as well as the safety of undergoing surgery, where medical conditions, prior abdominal surgeries may come into play, which may limit certain types of reconstruction. Finally, I'll be spending a considerable amount of time discussing the impact of radiation therapy and how it affects decision-making for breast reconstruction. In the US, the most common type of reconstruction is implant-based, accounting for about 3/4 of all types of reconstruction. Autologous reconstruction is a name used to designate using a woman's own tissue to reconstruct a breast. Other terms include flap reconstruction, and I'll go through the different types of flaps that are available. Finally, an implant and a flap can be combined into a hybrid type of reconstruction. It gets confusing when we talk about the timing of reconstruction. Most commonly, we offer immediate breast reconstruction, meaning that we begin the process at the time of the breast cancer surgery, which may be a mastectomy or a lumpectomy. Delayed reconstruction means that the timing of the breast surgery is separated from the reconstruction by as little as 2 weeks to as many as several years. Finally, delayed immediate reconstruction is a confusing term that we use to describe a combination of the two, meaning that we generally begin immediately with an implant as a temporary form of reconstruction, with the future plan to convert to another type of reconstruction, such as a flap, at a later time, traditionally after radiation has been completed. It's important to understand the different types of mastectomy because that really impacts how the breast looks and feels after reconstruction. The most common type of mastectomy is called a skin-sparing mastectomy, where most of the breast skin is preserved, but the nipple and the areola are removed. This can be oriented horizontally or vertically. Generally, when in smaller breasted women, we use a horizontal incision. In larger breasts, we use a vertical incision because it allows us to reduce the excess skin in the breast and gives a more lifted appearance. More common these days are nipple sparing procedures, which can be done through a number of different incisions. Finally, in very large breasted women, we use a skin reduction technique where much of the lower part of the breast skin is removed, and then the remaining skin is used to shape and mold into a more lifted, smaller creation of a breast. When a mastectomy is performed, not only is the breast gland removed, but a lot of important anatomic ligaments inside the breast are also removed. These suspensory ligaments are what give the breast its shape and its perkiness, and that's very difficult to reconstruct with both implants or with a woman's own tissue. So we use a number of different things, such as surgical mesh, to create the appearance of suspension. First, I'll talk about implant-based reconstruction, which I mentioned is the most common type in the US. It's most often done with a two-stage approach, beginning with a tissue expander, which is a type of implant that is adjustable in size. It's inserted at the time of mastectomy, usually with immediate reconstruction, and that tissue expander is filled with saline and added to fill volume over the course of several weeks. More popular these days is DTI, or direct to implant reconstruction, meaning that a full-size, usually silicone gel implant, is inserted at the time of mastectomy. Now, in order for this to be possible, it must be done safely where the skin has good blood supply at the end of the mastectomy. So we can never guarantee that we are able to do a single stage reconstruction at the outset, but usually that is our goal. Now, where the implant is placed has changed over the past few years, and that's probably been the most significant update in breast reconstruction since I've left residency. We were taught to place implants under the pectoralis muscle traditionally, and some surgeons still do this, where the entire implant is placed under the muscle, both the pec muscle and the serratus muscles on the side. Then this shifted to what's called a dual plane approach, where half of the implant is covered by the pec muscle at the top, and the lower half is covered by surgical mesh, also called acellular dermal matrix. In the past 5 to 7 years, we've shifted to a pre-pectoral approach, which means that the implant is sitting on top of the muscle, which is where you would expect, because that's where the breast gland has been removed. Not only is this more comfortable for the woman, it's safer, there's less bleeding involved, there's less pain after surgery, it's a shorter surgery, and in our experience, we found that the aesthetic outcomes, the cosmetic outcomes, are superior when compared to the muscle positioning. So why were implants placed under the muscle in the first place? Well, I think it has to do with difficulty with the type of the mastectomy that was performed in the early 80s and 90s. And now that mastectomy techniques have improved, we're able to focus on keeping the skin alive while removing all of the cancer safely. It has become much more of a popular technique. Capsular contracture, which is a problem with implants having too much scar tissue around them, has also been seen, and it's been thought that placing implants under the muscle can mitigate that risk. And that's primarily from literature in cosmetic surgery for augmentations. That hasn't really been the case for breast reconstruction now, mostly because we use acellular dermal matrix or surgical mesh to support that implant. So ADM is that mesh that I was mentioning. Why do we use it? Well, it really is only used to keep that implant in place. So after a mastectomy, only the skin is left behind, and all those suspensory ligaments from the breast have been disrupted. So we use this mesh, which is cadaveric skin, and we shape it around the implant or the tissue expander to control the pocket that is formed after the mastectomy. So it prevents the implant from migrating too far to the side, under the arm, or too far up or down. For tissue expanders, it also allows for quick expansion or filling of the expander. And then, of course, with direct implant reconstruction, this makes it very easy. There's some potential medical reasons for using ADM by reducing the amount of inflammation from exposure to the implant and potentially reducing capsular contracture, although the evidence for this long-term remains to be seen. So over the past 10 years or so, I would say the shifts in mastectomy techniques have allowed us to perform more nipple-sparing mastectomies by preserving the entire skin envelope. We've moved away from tissue expanders and have been using direct implant reconstruction much more commonly. And we've moved from placing implants under the muscle to partially under the muscle and now completely on top of the muscle. And this allows us to create a more aesthetic or pleasing breast by getting away from a flattened pancake appearance to more projection and natural droop or ptosis of the breast. So this is just a diagram showing the evolution of breast reconstruction with implants from submuscular to dual plane to now pre-pectoral reconstruction, which is shown on the lower right. This is an example of a woman from a few years ago when we first started doing pre-pectoral reconstructions. She had nipple sparing mastectomies for breast cancer. She also had a BRCA1 mutation, so we recommended bilateral mastectomies. She was a relatively thin woman, and we were able to do a single surgery, single stage with an implant on both sides. And here she is 2 years later with no revisions. Here's another example in a much younger woman who was identified to have a genetic mutation with BRCA1, similar type of surgery using nipple preservation through inframammary fold incisions and immediate direct implant with smooth round silicone gel implants. Next, I'll present some examples showing the effects of radiation on implant reconstruction. This is a 43-year-old who had right-sided breast cancer that was more advanced. So she had lymph node involvement, required a lymph node dissection on the right side, had direct implant reconstruction, and because of her lymph node involvement, she needed right-sided radiation. So here you can see there's a slight difference with elevation of the patient's right. The nipple is more elevated, the skin is tighter on the right side, and this is definitely more apparent from a lateral view or an oblique view. This is not the worst case of radiation fibrosis that I've seen, but it does illustrate that even in the best of cases, there is going to be some differences between the two sides after radiation. This is a different example of a woman who had left-sided breast cancer, bilateral nipple-sparing mastectomies through the same approach. She had direct implant reconstruction to a larger size. She was very thin to begin with, and you can see that evidenced by the lack of fat under the skin, which leads to more visible implant rippling or palpability in the upper parts of the implant. She did receive radiation on the left side. Here she is a year later, and you can see the left side starting to migrate up a little bit. And then here she is 3 years later, and there's a pretty severe capsular contraction on the left side where the implant has been malpositioned, it's been pushed up, and there's no great non-operative solution for this. So to correct a deformity like this, we usually recommend replacing the implant, removing the capsule, and potentially adding autologous tissue, such as a Latissimus flap in this case. Finally, what happens if we don't preserve the nipples? Well, skin-sparing mastectomy can be done. This is an example showing direct implant reconstruction in the pre-pectoral plane using transverse or horizontal incisions. You can see the incisions underneath the tattooed nipples, and this is an example of bilateral 3D nipple tattoos after about a year. Now I'm going to move on to the other major type of reconstructive technique that we often use, which is called autologous reconstruction, and that's just a term referring to using a woman's own tissue. There's a number of different types of procedures that are offered that are listed here. Donor sites can range from the tummy, the thighs, the upper buttocks or lower buttocks, and the back. By far the most common donor site is the lower tummy, which is the DIEP flap that you may hear about. The DIEP flap is an evolution of this procedure, which is the TRAM flap. TRAM stands for transverse rectus abdominis monocutaneous flap, and it stands for the tissue that's being removed. So we remove the rectus muscle along with skin and fat from the lower abdomen. As you can imagine, this is a painful procedure because muscle is being cut out, and this is quite morbid for the abdomen, so we no longer offer this procedure. The DIEP is now the most common type of abdominal tissue transfer. DIEP stands for the blood vessel name that is used to supply the lower abdominal skin and fat. So the blood vessel is removed from the muscle. We tease the muscle fibers apart using careful loop-assisted microscopy, and we're able to preserve the nerves to the muscle this way and just remove the blood vessels that keep the fat alive. And then we connect those blood vessels to internal mammary vessels in the chest, which are found under rib cartilage. And this, as you can imagine, is a complex procedure that only specialized centers perform. It takes a long time. So a one-sided breast reconstruction takes about 4 to 6 hours. A bilateral reconstruction may take 8 to 10 hours. So there's pros and cons to all these techniques, and I'm happy to answer questions about it, but it gets a little into the weeds when it comes to these different techniques. This is an example of what can be achieved with autologous reconstruction in one stage. A woman with DCIS, which is stage 0 breast cancer on the right side, and she opted to have bilateral mastectomies. And because of her body habitus, we're able to preserve her nipples and use her lower tummy for reconstruction at the same time. So this is all done in one surgery, one pretty long surgery, and she recovered well. And 4 months later, here she is looking very similar to her preoperative appearance, with the exception of a scar on her tummy. And she has soft, warm breasts, which is the main advantage of using your own tissue. This is another example of skin-sparing mastectomies, where the nipples and the areolas are removed and replaced with skin from the lower tummy. So later on, we can use that skin to create nipples, and I'll show you examples. This is an example of a 39-year-old with BRCA1 mutation as well as right breast cancer. She had larger breasts to begin with, and this was done in one setting with both mastectomies performed and transferring both flaps at the same time. Here she is seen 2 years later after nipple areolar tattooing. This procedure can also obviously be done in women of all sizes. So this is a relatively thin woman, BMI 22, with left-sided breast cancer. We perform skin-sparing mastectomies on both sides. And in this patient, she elected to have some augmentation of the breast using her own tissue. So we use a technique called Autologous Fat Grafting, which involves liposuction, processing the fat, and injecting that fat back into the breast to slowly augment the breast. So this took 3 additional procedures, but she was able to end up with a significantly larger breast size, as you can see here. And this she is seen 3 years later. So this is all of her own tissue in both breasts, no implants involved. Those are not her own nipples, those are tattooed nipples. And this was a very stable result after a few years. So that's the other main advantage of using your own tissue, is that there's often less likelihood of needing to revise these reconstructions after many years, whereas with implants, because of the issues with implant rupture and integrity disruption, we often have to replace those implants or do symmetry procedures at a later date. Now, what if we don't do the reconstruction at the same time as a mastectomy? Well, women may go through a flat period where they have no breast for a period of time. Then we do a delayed reconstruction. In some cases, we're able to preserve the skin, like in this woman who is seen here. But oftentimes we have to replace the skin, especially if that skin has been damaged by radiation. So what if we know that the woman needs radiation before her mastectomies? Well, we may know this because of locally advanced breast cancer, meaning that the patient may need radiation afterwards from lymph node involvement, but we can still offer immediate reconstruction using implants in the immediate setting. We call this a placeholder or a babysitter approach, where the implant is used to hold the position of the skin envelope. This allows the woman to undergo radiation, as in this case. This lady had quite a severe radiation reaction with the darkening or hyperpigmentation of the skin afterwards. Here she is with her implants a year later, and we usually wait 4 to 6 months after radiation is finished. Then here she is after swapping out the implants with her own tissue using deep flaps on both sides. And then she had one more surgery with minor adjustments to the skin on both sides and nipple reconstruction and tattooing. You can still see the sequelae of radiation here with the darkening of the skin, but overall the skin is much softer and has recovered, and there are some regenerative effects of using her own fat to reduce the problems related to radiation that we see. Another example of using a delayed immediate approach, right-sided breast cancer and a larger breasted woman who desired breast reduction. Here she is seen 6 months after tissue expander placement. And then here she is after a deep flap, and then a symmetry procedure later on with nipple reconstruction. So in very thin women, we can still do a deep flap, but sometimes we have to use both sides of the abdomen to create a single breast, and we call this a stacked deep flap. This is a procedure that we specialize in here at CTCA, as well as some other centers. So this is a relatively thin woman who has a moderate sized breast and not a lot of lower tummy tissue, but we're able to do a stacked deep flap at the same time as a mastectomy. This was done immediately. And then she had a minor symmetry procedure on the other breast called a periareolar mastectomy to lift up the nipple position. And here she is seen after nipple reconstruction. So what is nipple reconstruction? Well, if the nipple has to be removed, if a patient is not a candidate for nipple sparing mastectomy, then there's basically two options. We can either make a nipple in the procedure room or in the operating room using a patient's own skin, or we can tattoo it alone. So local flap nipple reconstruction, we take skin, adjacent skin on the breast, and we fold it into basically a cylinder into the shape of a nipple. So here's what that looks like before, during, and after. And here's what it looks like after it's healed before tattooing. Another example of what it looks like before and after tattooing. And this is a reconstructed nipple on the patient's left breast, her native nipple's on the right. So on the screen, it's the right half that's reconstructed. So it's a deep flap with a reconstructed nipple and tattoo. Same thing over here, reconstructed nipple and a tattoo. Now, if you don't want the appearance of a nipple that protrudes, then you can opt for a 3D nipple tattoo, and that's what's seen here, which is basically a picture of a nipple tattooed on the skin, which is flat, that has different shading to produce the illusion of projection. Finally, I'll briefly talk about oncoplastic reconstruction, which is a term we use for combining a lumpectomy or a partial mastectomy with breast reconstruction. So in some candidates who are women with larger breasts or more ptotic or droopy breasts, we can do a lumpectomy and a breast lift or a breast reduction at the same time, and that can offer better symmetry, especially when radiation is going to be performed. Now, we really prefer to do this at the same time as the lumpectomy or within a couple of weeks, because we want to get to the breast before radiation has a chance to take effect. So this is what happens when we can do this safely. You can see this woman is about 2 years out in the picture on the right, and she's had reductions on both sides, a lumpectomy on the right side with radiation. So you can see that the skin is a little bit darker, a little bit shinier, and the breast is slightly smaller, but this is still a very acceptable result after just one surgery. Finally, I must mention the Latissimus flat breast reconstruction, which we don't perform very often, but can still be useful for certain types of patients. This is a pretty dramatic case of a woman with locally recurrent breast cancer to this chest wall. She had to have a lot of her skin and part of her muscle resected from the breast. And because of how thin she was, her body habitus, the only option was to use her back. So we used the Latissimus flap from the back. It includes muscle, skin, and fat combined with a tissue expander. And that tissue expander can be exchanged to an implant later on. So here she is about 6 months later. So I'll pause there for a minute. I know there may be some additional questions that we'll take at the end. And then the rest of this presentation will focus on lymphedema. So in general, I want to talk about lymphedema in the setting of breast cancer. We treat lymphedema in many different ways, and sometimes we use surgery. So not a lot of women have heard about the surgical options for lymphedema because it's still fairly early, although we've been doing this for 10, 20 years now, but it's not generally accepted and not widely offered at most centers. So lymphedema is tissue swelling that occurs when fluid builds up, lymphatic fluid, which exceeds the transfer capacity of the lymphatic system. So the lymphatic system is a network of small vessels that are separate from blood vessels that carry extra fluid throughout our body. And a lot has been learned about this system in the past few years, but it mainly has immune functions. So whenever we come into contact with the outside world with our extremities, they carry bacteria or other antigens back to your lymph nodes from the lymphatic system. Unfortunately, as of yet, there's no cure for lymphedema, but we are working to improve the quality of life using surgery and other techniques. So in the setting of breast cancer, this usually occurs when the axillary lymph nodes under the arm, have been surgically removed and or damaged by radiation. And that prevents proper drainage of fluid from the arm into the rest of the body. Multiple factors contribute to lymphedema or lymphatic dysfunction, and they kind of work with each other and are synergistic in effect. So lymphedema is a compilation of different symptoms that include not just swelling, but also fibrosis or scar tissue deposition, inflammatory symptoms in the extremity, recurrent infections or cellulitis, as well as the inability to fight off infections in that arm. The most common risk factors in our breast cancer population is surgery, radiation, scar tissue that develops as a result of those two. Sometimes cancer can spread to the lymph nodes, and other effects related to a woman's body habitus, age, chemotherapy, that can all contribute to lymphedema. The symptoms of lymphedema obviously include swelling and heaviness in the arm. Sometimes the heaviness is so severe that it restricts range of motion. There's often pain involved, some flexibility problems, inability to fit into clothing, into sleeves, into jewelry with the affected extremity. And then the most severe complication is repeated infections or cellulitis and hardening of the skin. There's quite a lot to be said about the impact of lymphedema on quality of life, and it has a lot to do with the psychological morbidity, meaning that it contributes to depression, anxiety, sexual dysfunction, social avoidance, all these important issues that are part of survivorship. We're beginning to see a lot more of this now because, fortunately, the treatments for breast cancer are so good these days that women are living for decades after their breast cancer diagnosis, but the treatments for surgery have not really caught up. So there have been some improvements in how we deliver lymphatic surgery, lymph node removal, how the breast surgeons approach the lymphatic system when removing cancerous lymph nodes, but surgery and radiation still can't be avoided for a lot of patients who need that in locally advanced disease. We have to rule out other causes of swelling in the arm when a patient presents, and that may be related to a DVT or a clot in a vein. Local recurrence is always a fear that we must rule out whenever there's very acute onset lymphedema. And then sometimes, very rarely, radiation can cause a rare type of cancer called lymphangiosarcoma. I believe that the best way forward is to prevent lymphedema from ever happening. And our breast surgeons are working tirelessly to make this happen by using sentinel lymph node biopsies very judiciously for staging, avoiding lymph node dissection, or performing what's called targeted lymph node dissection in appropriately selected patients. We're having new studies come out that say that we may not need to deliver radiation for certain patients, and that is going to be great to help prevent lymphedema. Finally, what we've been offering is axillary reverse lymphatic mapping for patients who absolutely need lymph node dissections and procedures called immediate lymphatic reconstruction, or ILR, primary lymphatic bypass, or lympha techniques, which is a complex term for describing how we hook up lymphatic vessels at the time of lymph node dissections. So what happens if you are diagnosed with lymphedema? Well, we have to be very careful to prevent more severe sequelae of lymphedema, and that means monitoring skin hygiene, nail care, avoiding injury to the extremity, compression therapy, maintaining ideal body weight, early exercise and range of motion. I think antiquated recommendations like avoiding blood pressure cuffs and blood draws in that affected extremity have now gone by the wayside. Longer duration air travel still needs to be a consideration to wear a compression sleeve. We diagnose lymphedema mainly through examination and history. We can approximate the volume of the extremity using various techniques, but the simplest way is to measure the circumference around the limb at various points along the arm. We use bioimpedance spectroscopy, which is a non-invasive type of test, which looks at the water content of the abnormal arm compared to the normal arm. And then finally, we use more advanced imaging techniques in patients who are candidates for surgery. There's different ways to look at the risk for developing lymphedema, and that's listed here. This is more relevant for other doctors. Lymphocentigraphy is a test that we use to inject dye in the extremity to look for functional versus non-functional lymph nodes. And finally, we use high-resolution magnetic resonance lymphography in some selected patients in order to map lymphatic vessels that can be targeted for surgery. We use a technique called near-infrared indocyanine green fluorescence, which looks at fluorescent dye under the skin and how it drains in the extremity. And there's various patterns that can help us determine if a patient's a candidate for one type of surgery or another. There's various stages of lymphedema, going from latent or subclinical all the way to elephantiasis, or the most severe type of lymphedema. The mainstay of treatment for lymphedema remains physical therapy, which includes CDT, which is called complete decongestive therapy. And that is a combination of compression garments, manual lymphatic drainage, elevation of the extremity using lymphatic pump devices, and avoiding risk factors. And the rest of this I'll talk about is mainly surgical techniques that we use to treat lymphedema. There has been some interest in looking at medications to help prevent or treat lymphedema. Water pills or diuretics have been used in some cases, but they're traditionally reserved for leg lymphedema, and especially useful in patients who have a combination of other causes that make lymphedema worse, such as cardiac dysfunction, heart disease, bad valves or veins in the legs. Vitamin E and pentoxifylline have been useful in preventing radiation-related fibrosis that may contribute to lymphedema. Steroid injections have been tried, and other anti-inflammatories like ketoprofen have been studied, but none of these have been shown to be definitively curative or significantly improved in patients with more advanced lymphedema. Finally, these are some of the investigational treatments listed here, such as cold laser therapy, PRP, aquatic therapy, that have not really been shown to improve the symptoms of lymphedema. So what do we do for surgery? Well, first we have to select the appropriate indications for surgery. Patients who have failed medical management, meaning they have really failed conservative therapy, including physical therapy, or they've plateaued on their physical therapy over the course of 6 months or more, are candidates for surgery. Those who have had recurrent infections are candidates for surgery, and those with much more rare lymphatic malformations are obviously candidates for surgery. Unfortunately, there's still no consensus on the role of surgery, the optimal approach for surgery, or the appropriate timing for these procedures. So you may get a lot of differing opinions depending on who you see for lymphedema surgery. One of the things I rule out first is that there's no venous obstruction or constriction of the veins that may be contributing or making lymphedema worse. And this can be addressed with a stent or a dilation of the veins in the armpit area. The most gruesome or severe type of surgery that's performed is called the Charles procedure, which removes all the skin and subcutaneous tissue and in an extremity affected by lymphedema. We rarely perform these anymore. It's quite morbid and involves a lot of recovery and skin grafting. Two of the most popular procedures nowadays include node transfers and LVAs. So first of all, I'll discuss lymph node transfers. We use functional yet expendable lymph nodes from another area of the body. The most common area is the upper groin or the lower abdomen. Other areas include the neck or under the chin, or sometimes we use lymph nodes around the stomach internally. And these can be transferred to either the armpit or along the forearm to help reconstruct and reverse the changes of lymphedema. We don't completely understand how this works, but the pathophysiology suggests that there's some factors that the lymph nodes bring in to help generate new lymphatics. So this does work in a lot of patients, although it doesn't work in everybody. So we're still trying to figure out the proper patients to offer this procedure on, because it's a lot to go through. Lymph node transfers can be combined with breast reconstruction. So that's a more common approach we use. So for a woman who's already had a mastectomy with a node dissection and has developed lymphedema, we can combine this with simultaneous breast reconstruction using a deep flap, as well as lymph node transfer from the lower abdominal lymph nodes, which are right there. This does involve additional time during the surgery, because additional blood vessels have to be reconnected. But this is an example of a woman who underwent this procedure on the left side. She had lymphedema in the left arm, as well as absence of the breast from a modified radical mastectomy. And she healed well, and I actually went on to have LVAs, which we'll discuss later on. Other physiologic procedures include transferring lymphatic vessels from one area to another. And then our area of expertise is in lymphovenous bypass or lymphaticovenular bypass. This is basically a rerouting or a plumbing procedure. When the lymphatics have no place to drain, meaning that the lymph nodes are damaged or disconnected in the armpit, then lymph fluid fills up in the lymphatics of the arm. And when that happens, we have the opportunity to decompress these lymphatics by basically finding these lymphatics under the skin and the arm, and then using microscopic sutures to connect them to nearby small veins or venules. This already occurs in the human body near the heart. So this is not really out of the ordinary. It just happens in a different area of the body. So that's why this is called a bypass procedure. As you can imagine, this is a very technically demanding and complex procedure to perform, so it takes several hours. We use microscopic sutures, specialized instruments, and high power magnification in our microscopes in order to achieve this procedure. This is an example of a patient who had long-standing lymphedema for over 20 years in her right arm. She already had breast reconstruction, already had a flap for her breast reconstruction, but her lymphedema symptoms still did not go away. On the right side, you see my preoperative planning, which uses a combination of indocyanine green and preoperative imaging to find dilated lymphatics and identify areas where we're most likely to encounter these lymphatics that are amenable to bypass. These are some of the intraoperative photos that I've obtained with our microscope that shows the blue lymphatics that we use to light up with a blue dye. And in the pictures on the lower bottom and the right are the microscopic connections that we make from the lymphatic vessel to nearby small veins. Now, these are blood vessels that are often 0.5 to 1 millimeter in diameter. So they're microscopic, and fortunately, these work. Even connecting 3 or 4 of these tiny blood vessels can offset pressure from the extremity and lead to quite a bit of symptom relief. So here she is seen only 2 weeks later with already a dramatic improvement in the suppleness or the softness in her extremity. And last year, she sent me her photos about 4 years after her surgery, maintaining these results. In her affected arm, she's obviously still has some lymphedema in the forearm area, and then that's mostly due to fibrosis. But in the back of the hand, you can start to see the tendons there and the veins, and she's able to function much better after this procedure. Finally, liposuction is a technique that we can use to debulk the solid component of lymphedema, which is due to excess fat that accumulates and fibrous tissue or scar tissue that accumulates. But this is not the best procedure because it does relegate a woman to a lifetime of compression therapy afterwards. So the candidates for lymphedema, we always ask about the need for breast reconstruction because, as I've mentioned, this can be combined with an autologous type of breast reconstruction. We have to rule out cancer recurrence, so we must make sure that the cancer has been resolved. Sometimes ongoing chemotherapy limits the safety of these procedures. We can't perform these procedures in patients with active infection, and women must demonstrate that they've tried physical therapy and it has only plateaued their symptoms or hasn't really done much. Finally, the realistic expectations are very important to set straight before surgery, meaning that we can't cure lymphedema with any of these surgeries. We can often improve the amount of swelling or the bulk in the extremity, and the best of cases, we can reduce the amount of compression or completely eliminate the compression in some patients. I would say about a quarter of patients. The contraindications from surgery are no different than other types of breast reconstruction surgery that we have, such as active smoking or morbid obesity, metastatic disease, and other medical problems. Finally, we need more evidence and more outcomes data on the role of surgical therapy, on the role of liposuction, and on the role of primary prevention, which is the Lympha technique using primary lymphatic bypass at the time of lymph node dissection. So thank you very much, and I'm happy to answer any questions that you might have.
Thank you so much, Dr. Liu. We do have just a few questions. And so the first one that we have is, how does aging affect reconstructed breasts?
So I assume the question means after a woman has already had reconstruction, how does the
Yes.
breast age over time? That's a great question. I would say that it depends on the type of reconstruction. So because implants are the most common type of reconstruction, especially if a woman has had an implant on one breast and she has kept her own natural breast on the other side, we often see progressive asymmetry because the natural breast will age, it'll sag over the years, whereas the implant tends to stay in the same position. So we mitigate this by either exchanging the implant later on or tightening or a mastectomy on the natural breast. In a reconstructed breast using a woman's own tissue, aging seems to have little effect or a more symmetric and proportionate effect with the rest of the body and the other breasts. So like I said before, there's less need for revisions after autologous reconstruction.
Okay. Whoops. I'm sorry. Can you hear me?
Yes.
Okay, great. Thank you. And then with nipple sparing, and I think overall breast reconstruction, can you talk about feeling, whether or not women will still have feeling and how that will come back, and if it does come back to the full, I guess, feeling that they previously had before the reconstruction?
Yes, that's a great question. And there's a lot of ongoing research and some exciting developments in the area of breast sensation. I will say that traditionally would tell women that after a mastectomy, there will be little to no feeling in the remaining breast, even after a nipple sparing mastectomy, even though it looks almost like an exact replica of the breast, they may have no sensation in the breast, but it has to do with how the mastectomy is performed. So if the breast surgeon is able to preserve safely the sensory nerves that come out from the chest wall into the nipple and under the skin, then sensation can be preserved. But because the anatomy can vary so widely, and because we want to make sure that the cancer is all removed, that it's often not possible. So in order to get around this, we've been experimenting with techniques to reconnect the nerves at the time of the mastectomy, or more often at the time of the reconstruction. So that means using a nerve graft from either a woman's own body or more commonly from a donated cadaveric allograft to connect a nerve from a flap from the lower tummy that gives sensation to the tummy. And we connect that to a nerve under the rib. And that may allow some return of sensation, although it's highly unpredictable. If there is some return of sensation, it generally takes up to 2 years to see that. So I would tell women to be patient. And there is a lot of brain connections that are being made in a new breast. So a lot of that will come back on its own. And there's some techniques with physical therapy known as sensory biofeedback that can promote this. So basically retraining the brain how to feel a new breast can be useful.
Wow. Are there any particular traits or characteristics, maybe genetics, that increase the likelihood of lymphedema?
In genetics, not that we know of. That hasn't been as well studied as oncogenes or genes that are like BRCA1 and 2 that predispose a woman to a breast cancer risk. So I'm not aware of any genetic conditions that may predispose someone to lymphedema. However, we do know that there are genetic components because lymphedema does tend to run in families, and sometimes there's congenital lymphedema or patients who are being born with lymphedema from absence of lymphatics or lymph nodes. Acquired risks are much more common. So I would say that obesity is probably the most common risk factor that is acquired and adjustable, meaning that if a woman loses weight with lymphedema, oftentimes symptoms from the lymphedema will become less severe.
Great. And then the last question that I have for you is, should women who have had breast reconstruction after mastectomy get mammograms?
The short answer is no. So no matter what the type of reconstruction is, whether it's an implant or a flap, mammograms are generally not recommended because they pick up too many false positive issues related to surgery. So from a screening perspective, we don't recommend any screening imaging on the reconstructed breast. However, we do recommend monthly self-exams by the patient, same as a breast exam, feeling for lumps and bumps and nodules under the skin, because skin recurrence is still the most common after any type of breast cancer, regardless of reconstruction. Chest wall recurrence is rare, and that can't really be felt, but other symptoms may appear, like swelling of the breast or pain along the chest, and we do get imaging if those symptoms arise, but that's distinct from screening. So if there are symptoms, we will proceed with imaging that might include an ultrasound and or an MRI.
Great. Well, Dr. Liu, that is all we have for you. So thank you so much for joining us this evening and for your continued support of the breast cancer community. And we'd like to thank all of you for tuning in. We are so grateful that you could join us for this important event. We want to again express our deepest thanks to Dr. Liu and tonight's sponsor, Cancer Treatment Centers of America. This session was recorded and will be posted within the next week so that you can rewatch it. And we encourage you to share it with your family and your friends and your healthcare professionals as well, who you think may be interested in this important content. So thank you all again so much for joining us, and thank you to everyone who made this event possible. Stay safe and stay connected.